Okay, it's recording now. All right, this is going to be a pretty long review. So what I've kind of done is I've actually taken my review and kind of split it up into a PowerPoint to kind of help out those that just need a little bit more help. Okay. So when we're talking about twins and stuff like that, it's not going to be too far in depth. The stuff in red kind of helps out a little bit, but really just know the difference between what would be identical and what would be fraternal. Understand that with monozygotic or identical twins, it's going to be the same sex genotype. A lot of people who are fraternal can be the different sex, so it's pretty not too difficult there. Okay. Twins do increase with parity, so the more times they give birth with that. But really just with twins, we have the syndrome here on the bottom that we kind of have to look out for. That would be twin-to-twin transfusion syndrome. That's whenever we have twins have a common placenta and membranes, when it's kind of like they're fighting over the unequal circulation. One gets all of it while the other one does not. And outcome is usually poor for both twins. Okay. Okay, with fetal circulation, we're going to talk about this in a little bit on this next slide with kind of the adaptations that have been formed. But really just the key points to start out is while they're in utero, there's a lot of resistance in the lungs. So all of our oxygen and stuff like that is going to bypass it and go away from it. The placenta has very low resistance. And of course, it's going high to low. So low means it's going towards it. Our babies do grow cephalocaudal, head to toe, which means that, I guess in the development and everything like that, it's going top down, which is why we definitely do have our hands and feet kind of formed last. You'll notice by how their skin and stuff like that whenever they're born. The veins do carry oxygenated blood. It's going to be flipped than what you learned in A&P. Veins are carrying oxygenated blood and our arteries are carrying deoxygenated blood. And then of course we have 2 arteries and 1 vein for the umbilical cord. If there's anyone that needs a quick way to memorize that, for the 2 arteries, 1 vein, you could do a smiley face with the capital A's and then a capital V on the bottom. That could kind of help you memorize that. Okay, whenever it comes to these different things here, I would say if you are struggling with this, there's going to be a video on Khan Academy. If you just type on Google, put Khan Academy. Okay, that's fixed. Put Khan Academy fetal adaptations, and that will kind of break it down for you. And it'll really show you the patho, if that's what you may need to kind of help you memorize it, I would say. So just really breaking it down again, lungs and liver are non-functional. Circulation, that's not really the focus, they don't need their lungs until they're actually outside of utero. So it's a little different. The blood returns going from the placenta through the umbilical artery, through our passes that are going through the ductus venosus to the inferior vena cava. And pretty much this whole slide here, this would be helpful when we're talking about if you would like to screenshot it or something, or kind of screenshot the recording whenever I post that, to kind of show you the blood flow through the entire body. But we have 3 adaptations. We have the ductus venosus, the foramen ovale, and the ductus arteriosus. And I would say that you really could get tested on would be the stuff on the next slide here. I'll put that up there now. The way that I would kind of put this, if you're studying it and you're drawing it out, I would put the ductus arteriosus on top. And that A there makes it really helpful. Oops, sorry. Then, of course, the foraminal valve needs to be in the center because that's in the middle of this whole diagram that we're talking about. This pretty much pushes the blood from the right atrium to the left atrium. And then on the bottom, oops, someone's unmuted. It's okay, I can always unmute it. Mute you guys. Unless you guys want to say something, I don't mind. With the ductus venosus on the bottom, this is pretty much going from the umbilical vein to the inferior vena cava, so the bottom side of the heart, okay? And know that the venosus is the one that bypasses the liver, and the arteriosus is the one that's going to bypass the lungs. Okay. Okay, kind of a lot on this slide, but we're going to first start out talking about the placenta and their different functions. The placenta is really there to make sure that it's doing all the fetal respiration work. You know, lungs aren't working yet. It's providing nutrients to our fetus. It's going to be performing the endocrine function. So really the placenta is the one that kind of keeps out the big bacteria, but of course viruses can pass through there, such as measles, mumps, rubella, HPV, and HIV. It is both mom and fetus. And then we have two different sides here. The one on the left is the fetal side. That is the dirty Duncan side. And the one that I have on the right here is that shiny side. And then of course, note what I have in highlighted with the bacteria cannot cross the placenta. Viruses that are much smaller can cross. And then of course, things like, you know, alcohol and stuff can cross as well. So we have to be really careful. If there's any like section missing within our placenta here, we could have some impaired circulation. And then oftentimes, if you have a postpartum hemorrhage, one of the causes could be there's a fragment of the placenta still left inside mom. And the only way to kind of fix that would be to kind of do a very invasive procedure where they kind of go and, I guess metaphorically, you'd say they scrape it out. But I know one time I watched a video on a postpartum hemorrhage, and the cause of that one was because there was a fragment stuck in there. Okay, formation of the placenta, it develops at the site where the developing embryo attaches to the uterine wall. The development and circulation do not occur until the 3rd week of development. And once that placenta is pretty much made, it'll take over hormone production at 11 weeks. So that pretty much we have all of our different hormones here. And at first they're made by mom, but 11 weeks it's going to be taken over by our placenta. We have 2 different types of hormones, but I wouldn't say you really have to memorize that, but understanding these hormones that we're going to talk about and the kind of things that separate the two. So HCG is our pregnancy hormone with pregnancy test. It's the one that's present in the blood 10 days after fertilization. So as soon as someone's pregnant, if they were to take this test, that's why it wouldn't always be positive because it takes 10 days. This hormone does stimulate progesterone and estrogen by the corpus luteum, and it maintains pregnancy until the placenta is developed to assume the function. So it's very important, and that level each day will just keep rising and rising and rising. But if this level happens to ever like fall dramatically, it could mean that we've lost viability of the pregnancy. HCS, or human placental lactogen, HPL. This affects the breasts, and it produces breast milk. And we have to really monitor with this our diabetic patients, because these patients may need more insulin as it's kind of increasing their, I guess, blood sugar levels. Kind of kicking off of what HPL still is. have it on the top here that it's an antagonist. It's an antagonist of insulin. It increases the amount of circulating fatty acids for maternal metabolic needs. And it decreases the metabolism of glucose, which is why we're going to be needing more insulin during pregnancy. Relaxin, thankfully this one is in the name. It relaxes our cartilage and the pelvis and all the smooth muscle in the body. And this is the one that aids in softening the cervix. Okay, now going into our steroid hormones, we first are going to start out with estrogen. This is important for breast development, of course, puberty and maturity. This one stimulates the development to provide a stable environment for the fetus. And it does increase as we get closer to ovulation. A common sign and symptom of this would be breast tenderness. High levels of this could be increased libido, breast tenderness, cramping, maybe even increased blood flow to the uterus. This is the hormone that's usually in our birth control pills. And this is the one that we're going to be giving for moms that are in menopause. Okay, now into the one that everyone calls the pregnancy hormone, progesterone, pro-pregnancy. These levels need to be maintained throughout the level of pregnancy. And then we have these big words here, but really just, we have to make sure that it's stable to prevent a spontaneous abortion. The common signs of high levels of this would be with what's commonly called PMS, a cramping mood. This could be used if maybe our moms are having a history of miscarriages or a prevention of preterm labor. I just got a message. Or if we happen to have a corpus luteum that is just not doing its job, once that placenta is established, it takes over. Okay. Go into prostaglandins. This is the one that makes our smooth muscle contract. This is why with this, we could have a sign and symptom of this. Of a high level could be like diarrhea. Just think of it all relaxing. Low levels of this could be a hypertension patient. And then we could usually use prostaglandins because it kind of makes up the forming of our medications that we use to induce labor. So like things such as oxytocin or Pitocin. A lot of times this could even be with the what's called the morning after pill. But really the prostaglandin inhibitors are going to be NSAIDs, and that's kind of why the saying goes, NSAIDs are okay for the first month. I'm sorry, until the first month. After that first month, they can take it. Well, they cannot take it while pregnant because, you know, we don't want to close that ductus arteriosus in our baby. The heart would just not distribute blood, and then it would be a whole mess. And then when we're talking about implantation, memorize where this actually is. It's in the upper third of our uterus, often also called the ampulla. And it takes 5 to 7 days to travel between the actual fertilization and the implantation. Alrighty, going into genetics, really just for the stuff where you want to know, just basic stuff. Male determines the sex of the child. knowing the difference between a genotype and a phenotype. Genotype is the genetic makeup, and the phenotype is the physical traits. All right, now we're going to go into the different disorders. We're going to talk about the really basics of what they are, and then what also is an example. Okay, with an autosomal dominant disorder, usually one parent is affected. About 50% of the offspring will be affected, regardless of sex. The example of this would be a I can't even say it, but I don't think that would be out there. Huntington's disease. Wow, I'm thirsty. This trait here is actually heterozygous. So if you pull up the textbook, it'll go into like the, I guess the more detailed makeup of this, and you can kind of make up like a Punnett square and stuff like that. But just really what we have here. Okay, now we're going into the one that you probably want to focus on here. Autosomal recessive inherited disorders. Being that it is a recessive thing, we have to have two of them to, of course, affect the next offspring. The carrier is the individual who is heterozygous, so that means they don't have both to be the affected individual. So pretty much, of course, you have the dominant and you have the recessive. This isn't the recessive, so if at all that, it has the dominant, it's just going to be a carrier. The two carriers can for sure meet and pass on the same abnormal gene, and then we could actually have an affected child. In the case both parents are carriers, about 25 of them will be affected. And then I guess examples of this would be cystic fibrosis and the sickle cell, and then BKU. So this one's pretty easy to kind of remember as well. It's all about that recessive gene being the one that's kind of messed up. Okay, going into the X-linked recessive inherited disorder. Know that this abnormal gene is on the X chromosome. The X-linked disorder is shown in the male because they only have one X chromosome. So usually there is, with this one, there's no male to male transmission. The males are affected, they are related through the female line. Usually with this one, the mother is the carrier. And really just, the male has only one X chromosome, so that's why this is, because men are XY. So that's kind of what that is. Alrighty. What are the chances in the next pregnancy of an affected child? There's about a half chance that a carrier mother will pass the abnormal gene to her daughters, who then would probably become carriers because, of course, they have the non-affected and the affected gene. Oops. Okay. But I guess these slides kind of make it a little better, I would say. And an example of a common linked X-linked recessive disorder would be color blindness, hemophilia, and then Duchenne muscular dystrophy. Okay, now going into more of your week one stuff with the egg and sperm kind of talk here. When it comes to the viability, they have two different times. Sperm is made at puberty, and then of course it's continuously being made. But whenever we're talking about eggs, they're made at utero, and of course they mature at puberty. And the eggs live about 24 hours, but with eggs we do have a certain amount as well, a finite amount rather. Sperm can be stored in the genital system up to 42 days, depending on the frequency of ejaculations. Once ejaculated, it can actually live 48 to 72 hours in the female genital tract if they're healthy and highly fertile, which is healthy and highly fertile for 24 hours. And eggs live about 24 hours. They're very healthy. Within this stuff here, it's very long, but I would say just I'll give it a little pause so you can take a picture or something because it's pretty long. But pretty much it's in the name, spermatogenesis, and it's kind of the production of the sperm. Okay, I'm going to keep moving on. Okay, that was week 1. Now going into week 2, we've already gone on over much of week 2 stuff. It's in our kind of PowerPoint that we went over at in person on Wednesdays. But we do have some ways to kind of memorize this. Brad's, or that's kind of more abdominal breathing. The phrase I think was that I learned was Brad's go to the gym to get abs, so abdominal breathing. Lamaze, we do have that pattern of A's, the double A's there. So that's patterned breathing. With Kitzinger, I guess you just have to memorize the K and the CH for, but I mean, when you really get to know these things, it's not that, you don't have to really think of the memory way, but I mean, it can always help you last second, you know. And then of course, hypnobirthing, think about, you know, relaxation, deep and slow breathing, things like that. And that is the deep breathing side of it. Kind of like when someone's trying to be hypnotized, they might. Yeah, with this week 2 content, I would say you could have a question on this stuff right here with these topics. I mean, they might just describe what we're talking about here and then be like, which one is this? And it could be maybe like Bradley, Lamaze, you know, those 4 choices right there. And again, you can take pictures. One thing you could do as well when I post the video during your studying process, you really could just pause it on the recording that I'm going to post to you guys, and that'll can help you out as well. Next, during week 2, we talked about fetal milestones, the difference between the 3 trimesters. So let's go into the first one. Okay. In the first trimester, what the parents usually kind of feel as ambivalence. You know, there might be some fear and the future, things like that. The dad often lags behind in terms of accepting the pregnancy. And within that first positive test, they could be very nauseous, very exhausted. Just a lot of fear, you know, lots of changes coming to their life and stuff like that. Within the second trimester, I remember Harold talking about that it's the golden time. You know, you've accepted the pregnancy. You tend to show that look like, hey, I am pregnant, you know, be proud and stuff like that. It's also that nesting period as well. So I'm going to put it on there. They could be starting to plan ahead and, you know, really get prepared. And enough is enough. They could say, I'm ready to have this baby. I have written down that it's easier when the baby is inside. Baby isn't sitting on the bladder during this time. So usually whenever we're talking about bladder issues, it's in the first trimester and the last trimester. Of course, the last trimester is because it's, you know, putting all that weight on that bladder there. Okay. And really if you had to find a way to kind of think about that a little bit more, think of the third trimester as the time of like descent and a lot of weight. Within the second trimester, the father's reaction could be anxious, realizing have to kind of mature and stuff like that. And then the third trimester is really just overall, making sure they're going to like classes to kind of prepare for the birthing process, and really just dreams are happening in this period for the parents. Okay. Within our little ways that we have to kind of remember this, are heart tones and stuff like that. At 4 weeks, there is a heartbeat. You can't hear it, but it can be seen via ultrasound. The male and female organs are beginning to differentiate. At 8 weeks, we do have when all of our major body organs are formed. That is usually why in the first trimester, it can be very harmful if they didn't know they were pregnant and maybe they're doing some drinking or something like that. Understand these different things here. Whenever we're talking 8 to 10 weeks, that is with the Doppler. And then of course, 9 to 10 weeks, all the organs are formed and all it has to do is kind of grow. So the baby's bigger and the uterus is out of the pelvis. You can see the baby and you can actually hear the fetal heart tones with the Doppler. Okay. Oops. Okay, going into that second trimester here, at 16 weeks, the baby's sex can be seen, although very thin. The fetus will look like a baby. And difference with the heartbeat here, understand that first one before was the Doppler, and now we're talking about a fetoscope. 18 to 20 weeks is going to be heartbeat can be heard with a fetoscope. And you can really, if you're writing notes down, you can match up next to that also at 20 weeks is when we have quickening present. Also called flutters. And really you could just match up those Fs there. Fetoscope and flutters are about 20 weeks. The fetal growth goes from top to bottom, of course, cephalocaudal. Around 24 weeks with assistance, the baby can live outside the uterus. Basically, this means viability. 24 weeks is the viability term, but they might have to go into like NICU because that is still pretty much very preterm, but that's all it's saying is that at 24 weeks, they are able to live outside the uterus. Of course, at 24 weeks, they are much younger and much smaller, less likely to survive. But in the terms of the textbook, it is viable. I think I've been muted. I'm so sorry. So for this slide, all I talked about so far was that with the 1/6 of blood volume is in the uterus, and really ways to kind of memorize the H, C, and the G. Going into that, if you're writing it out, this one's pretty helpful because it actually does match up with the HCG hormone, but the signs of pregnancy we have on the top here, H, and that is usually going to be associated with our uterus. We have the C, which is of course C for color. And then Goodell's sign is on the bottom. This is going to be associated with our cervix. And I'll post these right here. Okay. Okay. Of course, there's another adaptation that happens when it comes to the mucus plug that is formed. This mucus plug is really just to make sure that there's no bacteria, getting inside. And it's really a safety thing that's made. So pretty much the endocrine glands secrete a thick mucus that accumulates to form the mucus plug. It's going to seal the cervical canal and prevent bacteria or anything to enter the uterus. This is actually expelled when the dilation process begins. So kind of how it goes is labor starts, cervix is going to dilate, mucus plug comes out, the body is overall just getting ready for labor. Alrighty. As we go into this slide, we are about a third way through the slides here. So I'm going to go ahead and take a quick little break, let you guys take a break as well. And I'll pause the recording as well, so we'll be okay. All right, guys, we're back talking about, of course, a lot of blood here. Their H&H levels are actually going to go down as pregnancy progresses. But overall, they're increasing in plasma volume. Their leukocytes, white blood cell counts can rise. And pregnancy is a huge stress on the body. That's why if you're ever looking at a question like postpartum, like for example, day 1 postpartum, and they have like a slight fever. Oh, I'm back. We were taking a break. That's why we were muted. That's why, if it's like day 1 postpartum and they have a slight fever, that's probably what it is here. Just a huge stress on the body. Okay. Do you have your headphones? Okay, moving on. With cardiovascular, really, this is talking about knowing how to fix superior vena cava syndrome. So pretty much what that is if we ever have a mother that's laying supine or on their back, we need to kind of rotate that, turn them to their side. So if we have a patient that's like on a blackboard, or like let's say like they have a spinal injury and on their back, something like that. We have an increased red blood cell production, but a greater increase in plasma, which is equaling a net decrease in H&H. Of course, we have a higher workload for the heart, which is increasing the cardiac output. Not as important here, but we have blood pressure decreasing in the second trimester, but going back up. And really just with cardiovascular, I'd say focus on supine hypotension, also called superior vena cava syndrome. Okay, we have the skin here. We're talking about the I would say their platelets do decrease, which is why we have an increased risk of postpartum hemorrhage. Okay. With the skin, well, we've already hit on this stuff in our past PowerPoints, but teaching with this stuff, if they're concerned about the linea nigra, kind of how that kind of goes, telling them that this is going to fade away. We do have the mask of pregnancy, also called chloasma, and then we also have stretch marks. And then the rest of this is just kind of more, it's not as priority for the studying, but it's just common stuff. They're having some sleep problems. They are going to have more blood flow to their airway. They're probably going to have some nosebleeds. Oh, it's just common. And then talking about colostrum, but that's on the later content in our course here. The teaching behind it, it's okay to breastfeed with colostrum. So. Okay, within the urinary tract, during that third trimester, the baby's head is bigger. So overall, it's just all that weight compressed on their bladder. The bladder will be underneath the baby, and it's, we want to encourage them to go pee every hour. They are an increased risk for UTI, but they may not ever show signs and symptoms of this because, of course, UTI symptoms is just going to pee a lot. And understanding UTIs can cause preterm labor. That's what that PTL means. Undiagnosed UTIs can, of course, travel up to the kidneys and cause pyelonephritis, just kind of a complication of that. Within musculoskeletal, they might have a slight abnormal gait with the separation of the pubic symphysis. Not as important, but we could also have lordosis of the spine. Really just this is going into the hormone of relaxin here. Their glucose within metabolic could spill into the urine. Increased blood sugar is normal because glucose is harder to metabolize for their kidneys. Not really sure what I put for BMR there, but they have a higher increased oxygen consumption. But I don't think that's, I don't remember what I put there. But I guess the really focus here is talking about the blood sugar levels. And going into the next thing, we're talking about weight gain, average weight gain during pregnancy. We have some different kind of, I would say what the kind of wants are. So if they're higher in the BMI scale, we want to have them gain less weight. And then if they're on the lower scale, or maybe they are, for example, okay, thank you for coming. And then if they're underweight or maybe even just a teenager, we want them to have a higher weight gain. And I would say that NCLEX that I kind of learned with Mark Klimek, he talked about that if you're trying to find an estimated weight gain throughout pregnancy, you could really take the number of weeks and subtract 9 from that. And that would give you a set number. And that's kind of your estimated weight gain. And if it's like a huge difference, like I would say 10 or so, then you need to do a biophysical profile and really assess the size of that baby. We do have these 3 P's of pregnancy. We have presumptive, the S there for subjective. We have probable for objective signs, and then positive as well. Starting out with presumptive, this is usually the signs of not something that's really, it's kind of the beginning stuff. So a late period, morning sickness, breast tenderness, they claim they feel a baby, claiming a positive pregnancy test. The reason we say claim there is because if they have a pregnancy test that's positive at their house, there could be a mass number of things that can cause that. So it's just simply a presumptive sign in the beginning. Of course, later, if we have a test again at the clinic, then that would be an objective sign. We have the abnormal pap smear. That could be a blue tinge. They're having some changes in the pelvic organs, change in the uterus, a larger abdomen. They could have a false labor contraction. We have the uterine souffle. It's described as a blowing sound with auscultation over the uterus. This is due to an increased blood flow through the placenta. We have skin changes, and we have, of course, the fetal outline as well. But the positive, the diagnostic ones, are the for sure, it's going to be an ultrasound at 4 to 5 weeks, or hearing fetal heart tones. It could be a fetal heartbeat with a Doppler at 8 to 10 weeks. It could be fetal movement at 20 weeks. And then, of course, another one would probably be like a fetal on the X-ray. Okay, estimating a estimated date of confinement, or also called the estimated due date. You take that first date, and please remember the first date, not the last date, the first date of the last menstrual period. You're gonna subtract 3 months, add 7 days, and then of course add a year if they were testing you on the year. Full term would be 48 weeks. I'm sorry, 40 weeks. Assuming that they do have a 28-day cycle, the average of ovulating on day 14. Assuming also that we did get that accurate last date of menstrual period. Assuming that they're on no oral contraceptives, and assuming that they are planning on breastfeeding. But really, it's those first three that are what we're kind of assuming. Would you be tested on that? Probably not, but you really will have to use, I would say you have to use this rule on the exam. Okay, we do have also the McDonald's rule. Not really sure why it's called that, but pretty much this is just measuring that fundal height, and that measurement in centimeters is going to be the estimated weeks. And this is used whenever we have a mother come in. She doesn't know her last due date. She's, her first ever visit could be at the even at the ER, and may have not had any prenatal experience. This could be false though. Whenever it comes to maternal height, maybe it's a very tall mom, maybe it's an irregular fetal growth, maybe they are, a small for gestational age baby, or maybe the mom's diabetic and the baby is just really big. This would kind of impact that. Maybe there's twins in there, or maybe there's an abnormal amounts of amniotic fluid, where we're talking about olyhydramnios or polyhydramnios. And when we're talking poly is going to be the very high number of amniotic fluid, and oly would just be the lower number. With a sonogram, we can detect a gestational sac as early as 4 to 5 weeks after the last menstrual period. The fetal heart activity is usually found at about 6 to 7 weeks. We have fetal breathing movements around 10 to 11 weeks. We have the crown to rump measurements to assess the fetal age from 4 days to 12 weeks. And then we have the biparietal diameter. This can be made by around 12 to 13 weeks and are most accurate between 14 to 26 weeks. This biparietal diameter is used to estimate the estimated due date, and it's usually within 7 to 10 days. It's a little more kind of strategic, rather. Okay, going off of the prenatal experience, this is what we usually want to happen, but with prenatal, it's going to be, the rule kind of is it's, less often in the beginning, and then the closer we get, we want it to be more common to see your doctor, your provider. But of course, so we have any risk, maybe they have a risk of, or a history of preterm labor, maybe they're hypertensive, anything like that. We want to make sure they're coming in more than usual if that was the case. And really the goal of this prenatal labs is we want to make sure that we're being able to identify and treat any problem that we find early. If we have, for example, maybe the RH factor, we want to be able to be doing the teaching and saying, hey, at 28 weeks, we may be doing, giving you RhoGAM, and then we're also going to do that 72 hours postpartum as well. Or if you probably wouldn't teach them it, but you'd be like, if there's anything invasive, or if you get cut or something like that, we would do, it'd have to be a pretty deep cut, but you'd have to do a thing of RhoGAM if was needed. Anything that can cause a mixing of the blood. And if these patients are getting RhoGAM, we want to wait 7 months before getting pregnant again. And we've, we kind of touched on RhoGAM. I wouldn't say RhoGAM, but the RH factor, whenever you guys took your AMP2. But we usually have problems with, if it's an RH negative mom, because there's no antigens, or in an RH positive fetus, which there is antigens, and pretty much this is all summarized by the mom is making antibodies for the suspected invader, okay? We have two tests here, the direct Coombs test. This is done on the baby. Think about it as directly on baby. And this is to see if there's any antibodies attached to the fetus's red blood cells. With the indirect Coombs test, this is done on mom to determine if there's any antibodies. Antibodies and sensitization are usually coinciding of one another. So if you have for example, a positive indirect Coombs test, that means that there has been antibodies made. Would you give RhoGAM in that situation? Probably not. Well, I think the answer would be no, because if there's already antibodies there, I mean, what's the point of kind of making it? The whole point of RhoGAM is to kind of trick the mother's common body into thinking that there is already antibodies produced in a way. Alrighty. Other labs here would be the hepatitis B surface antigen. This is testing for Hep B. The hepatitis B virus is the most common infection in our fetus. It's transmitted through the placenta and even during the delivery process. Infants born with Hep B should be treated 12 hours after birth. And highlighted here, we have Hep B can be given during pregnancy. Alrighty, with herpes here, if H. herpes simplex virus, they can give birth vaginally if there's no outbreak, like positive, like open lesions. CMV, cyclomegalovirus. The teaching with this is we want to make sure that these mothers here are staying away from anyone positive, even if the mom has it and a kid. Anytime you see this word here, any answer to question or choice is probably going to be stay away from this. This is transmitted through urine, semen, secretions, feces, breast milk. Okay, torch infections. Usually we're talking about cats or uncooked meat. The teaching is to just, if you can prevent it. If it's you can have a cat, but just don't do the litter box. Have your partner do it. And then just cook the meat to like medium. Okay, we do have a lot of tests here, but this is kind of the stuff that really distinguishes between the two. We have the RPR VDRL. This is essentially talking about syphilis. I would say parentheses syphilis. We're testing because syphilis can cross placenta, and we're going to be treating them if it is positive with penicillin at around 36 weeks. The quad screen is an optional screen, and it is around 14 to 18 weeks. Once she passes for 18 weeks, you shouldn't be offering this test. We have the alpha fetal protein, and then if you just want to put an arrow, elevated levels indicate neural tube defect. Decreased levels indicate Down syndrome. Okay, within STIs, this is very important because this can lead to a miscarriage or infect a baby before or during delivery. But the overall term of this is all STIs can cause preterm labor. Next, we have the GBS screen, group beta strep screen. This is at around 35 weeks. This one's done usually before our induction of labor and stuff like that, because this is kind of getting closer to the delivery process, and we want to make sure that it is taken care of, or making sure that this is a negative result, because this can be transmitted during from the birth canal of the mother. And then we have the cell-free DNA. This is not a diagnostic test. Please write that down. Cell-free DNA is, they are pretty much looking for trisomy 13, 18, or 21. If these tests are abnormal, they are going to then go into a CVS, chorionic villi sampling. Okay. Or an amniocentesis. So pretty much cell-free DNA, think of it, the term free is really giving it off some vibes that it's not as invasive. And then we're going to be doing more invasive procedures if this is abnormal. This is done around 10 weeks to kind of see if there's any chromosomal abnormalities. This is an expensive test. This is it is a kind of elective test, and it is not diagnostic once again. Okay, the next slide we're going to talk about is if. They're usually, these two things are taken if we get a abnormal test here, but really we're talking about CVS and the amniocentesis. Within the chorionic villi sampling, this is a very, not very, but this is invasive. So this, just assume that it's more, I guess, I don't know how to explain it, but it's more diagnostic rather. This is they're taking a sample of the chorionic villi. They're taking the cells and they're culturing them. And they're also doing a karyotype on them. How does it compare to the amniocentesis? There are risks to each, but we kind of have here what is here. So the CVS, it's the villi and the chorion can be pulled out of placenta at early gestation. This could, very low risk, but this could cause a miscarriage or a limb defect. And we have blue here, what it actually is. This is the small sample of the chorionic villi from the edge of the placenta. But later, because we have here 10, 13 weeks is CVS, and then later would be the amniocentesis. If you're talking about genetic makeup, at 15 to 20 weeks, we have the perinatal diagnosis is around 15 to 20 or 21 weeks. Note that cell-free maternal serum testing is becoming more utilized now. And with the amniocentesis, with that word centesis there, we're talking about a big needle. It's inserted through the abdominal wall and it's collecting amniotic fluid. Okay, team. Okay, next will be the non-stress test. And if you guys, to kind of help plan this out and study it, I would, if you want to put it like in chronological order, I would say that kind of helps sometimes. And once we get into, I think it's exam 2 that we have a lot more of these tests going on. But with the non-stress test here, we have, this is really just, it's non-stress, they're just trying to observe and see what's going to happen. It says they're looking for a normal 2+ acceleration of 15 beats per minute, lasting 15 seconds over 20 minutes, or they're looking for an acceleration of 10 beats per minute, lasting 10 seconds. Okay, next, it's kind of in the name, we have a contraction stress test. This is they are doing something that can stimulate a contraction, and think about a contraction as like squeezing here. So pretty much it's really just they're evaluating how that respiratory function occurs during the simulation of a contraction, rather. They're seeing if they're doing okay. They're seeing if they're able to kind of still breathe properly during a contraction. Okay, team, with rubella, this vaccine we are not giving while pregnant, and if they do get this, we don't want them getting pregnant for 1 to 3 months after as well. We're going to do a rubella titer. If it is greater than 10, they are immunized and they're okay. But if that is less than 10, after birth, we're going to give them that vaccine. So that's what that would be. Within the urinalysis, we're assessing for UTI. We're assessing if there's any, of course, if it's cloudy, if it's any glucose in there as well. So that's kind of what that is. And then increased protein in the urine could also indicate preeclampsia because they are going to have proteinuria. But that's more talked about later stuff. But going into the different danger signs next. This is going to be more about like bleeding and stuff like that. So let's go into that right now. Okay, within our danger signs, these are the ones that you want to report to your provider, and you're probably going to come in. Okay, team. Like if you have a sudden gush of fluid, this is what we call premature ROM. Anytime you see that in OB, it's going to be rupture of membranes. Maybe they are having vaginal bleeding. They could have abrupto placentae, placenta previa, things like that. I don't think, I heard that you guys aren't going to be being tested on those terms right here, abrupto placentae and placenta previa, but we shall see. I don't think so. Then we have abdominal pain. If it's premature labor, the pain is going to be kind of in the abdominal area. If they have a high temp, we're really looking for infection. It's not normal for moms to have infections during pregnancy, so this is kind of a danger sign. Because the mothers, the mothers know their baby. If they think that there's been decreased movement, or their family's saying, oh, it's just sleeping, but the mother has a feeling that it's just been decreased, they will probably come in because it's better be safe than sorry. It could be things that can kind of cause this to not be able to feel the movement would be obesity. Maybe it's a fetal death. Maybe they're just in distress. Of course, we're going to talk about this on a later slide, but hyperemesis gravidarum, that's going to be persistent nausea, vomiting. That's kind of what that is. We're going to talk about that in a later slide and what to do with that. if we have any visual disturbances, if we have any epigastric pain, if we have a headache or periorbital edema pretty much ever as well, we're thinking preeclampsia, also called pretty much pregnancy-induced hypertension. Some of the confusing ones, of course, are back pain, abdominal pain, headache, heartburn, UTIs, of course, our discharge, fetal sleep periods, persistent vomiting. It kind of does change, and how they're kind of describing it could really change how serious you can kind of assess it. Okay, next is going to be the discomforts of pregnancy. I believe that you guys might have had a assignment for Harold that might have been to submit this stuff. So if someone could just type in the chat if so. But we do have morning sickness. This is caused by the hormone HCG, very common in the first trimester. Self-care of this, they're going to make sure that they are eating, of course, crackers before getting out of bed. Okay. Okay, thank you. So pretty much a lot of stuff's in the book, so we're just gonna kind of skim over it, but we kind of have in red here what it kind of is. But I'm just gonna kind of skip through it because it should have been on your assignment, and I kind of remember doing it myself. But I would say don't sleep on this, especially as you get ready for the HESI. They could have you answer questions that are like, what would a mom do for morning sickness or something like that? Okay. Teaching as well with back pain. We don't want them to be laying supine straight on their back. We want to make sure they're laying on their side. Here we go. Okay, let's talk about preterm labor. With preterm labor, there's a lot of factors that can go into it. Maybe they have a high blood pressure, or they're preeclamptic. Maybe they have a history of STIs, UTIs. It could be any chronic condition. Sadly, it could also be drug use. It could be a stimulant. It could be cocaine. That would be for that. They could have very high amniotic fluid. There could be twins, or they just could have a shortened cervix. One of the things too is less than 12 months since the last pregnancy. Okay, we have signs and symptoms of this. It could be a low backache, painful menstrual-like cramps, suprapubic pain, pressure, the feeling of heaviness, and then of course their vaginal discharge could just be getting thicker, bloodier, or even thinner as well, with how blood kind of is. Within the immediate treatment, we want to empty their bladder so we can really properly assess. We want to make sure that they're on the left side, give us some water, and palpate the abdomen for contractions. If their contractions are, the frequency of them are less than 10 minutes, so that means that if it is coming and going less than every 10 minutes, like the start to start, then we want to make sure we're kind of putting more focus on that, because that could be definitely preterm labor. There are some meds here that that are on this. I would say just write this stuff down, but we do have the teaching of terbutaline, also called breathing, is that this is contraindicated in asthma patients. We do have tocolytics, and tocolytics, for those that need a little extra help, tocolytics are going to be preventing the preterm labor process. Believe it or not, although we always talk about mag sulfate with being a preventing seizures and stuff like that, mag sulfate actually can be a tocolytic agent. Okay. Then we have, of course, to have different side effects. But the one that is not a tocolytic would be betamethasone. This is a steroid, think of Sown steroid, given to mom to stimulate the maturity of the baby's lung. Increased preterm actually does occur. This is pretty much, hey, a steroid, we're kicking it in to stimulate the maturity of their lungs. Okay. Within nutrition and pregnancy, adolescents need to consume enough to meet their own needs. You know, of course, them themselves, they're still maturing and growing, so they're going to have the need to have a lot more nutrition value. Anyone that is having a close pregnancy interval, so less than a year between pregnancies, needs to have an increased nutrition. If they are having or if they're just multi-parous, so they've had multiple births. If they're planning on lactating, they need increased food intake. And really, it says here the body needs at least 9 months to build back those nutrients. And really, if it's closer than that, they just need some increased time, increased value of nutrients as well. I do have the sources of iron on this next slide here, but you need to know if you got a nutrition question, it'd probably be something like that's on the slide here. You need to know sources of protein, iron, foods that increase iron absorption. I believe we talked about this in one of our SI sessions in person. Within these stimulants, I would say observe the herbs that can actually serve as uterine stimulants, and then just it's not known every day that it's a uterine stimulant, so you have to do teaching. Okay, going to the next slide. We do have it's important to avoid foods high in mercury. We want to be giving them fluids. No raw or undercooked meat. We want to make sure that they're eating food at appropriate temps. And just really like always with vegan and vegetarian, we need to supplement with B12. And I would say this is for the iron thing here. We have eat lots of iron. And this is the thing that we could use. Just give it a few write it out on your paper, and it might help you kind of memorize this stuff. But the phrase is just eat lots of iron. And sadly, it doesn't go correctly with, so we have the pea here and the potatoes, but pretty much with that. Okay. Going into next would be substance abuse. When we're talking about alcohol, it's FAS, fetal alcohol syndrome. This one's very harmful, and it results in growth restriction, behavioral disturbances, brain effects, spinal defects, genetic differences. It's the most common preventable disease. Alcohol does pass that placental barrier within minutes. Everyone reacts different to these substances. Sadly, once the damage is done, it cannot be reversed. Absolutely do not drink during pregnancy or breastfeeding. With the breastfeeding, kind of emphasize that if they do a pump and dump, which is where they pump and dump and then try to then go again, that doesn't itself fix the alcohol in the system problem. So it's just encouraged not to drink. Pregnancy, any substance abuse can cause a spontaneous abortion, and it can just overall result in any subsequent problems throughout pregnancy itself. Methadone is the drug of choice to kind of help out those that are dependent on opioids and heroin. It does cross the placenta, and fetal exposure in utero may result in NAS and the newborn. Methadone is legal, but very unpredictable. And the teaching of methadone, the one that I think you have to really emphasize on, we do not want to try to withdraw this while pregnant, because if you get that mother to go through withdrawals, that can be more harmful than just keeping it there. So this can be bad for the baby if we were doing a sudden stop of this med. Okay, with our stimulants, this is when we're talking about nicotine, cocaine. Think of it as stimulants, as it's a vasoconstrictor. It's going to contract our uterus to maybe even cause an abruption placenta. But this could cut off circulation to the baby. And really, cocaine is the worst stimulant. I believe I've even had a question on that for NCLEX prep. Marijuana is unknown risks for mom and baby. Really, just this marijuana could not always be real. It sometimes can be synthetic. And marijuana, there still isn't much studies done on it, so the recommendation is just to stay away from it during pregnancy. Okay, diabetes in pregnancy. This is the main contributor to gestational diabetes. If the hormones of human placental oxygen. So pretty much HPL acts as the insulin antagonist. It increases the amount of the same thing that we've already talked about earlier, but HPL increases the normal glucose level within the mother, and this could result in some moms becoming gestationally diabetic. Within these diabetic patients, it's more difficult to control. We might need to affect our insulin levels. Hypertension could really occur as well. Within an established diabetic patient, their blood sugar levels will just get worse, and they're more likely to start more insulin therapy as well. Diabetes in pregnancy continued. This does have influences. It is an increased risk of perinatal mortality, an increase of congenital anomalies, so like abnormalities, increased risk of hydramnios, increased risk of preeclampsia, or even labor dystocia. Really, labor dystocia is because the baby could be just LGA, large gestational age, and it just makes the laboring process a little more difficult. Okay, within fetal macrosomnia, this is just increased growth due to, they've been getting so much sugar in that uterine process that once they're out, they think of them, they're just shitting it. They're sitting in sugar for a long time. This could even cause intrauterine growth retardation. RDA, I'll have to search that up. I forgot what I put that for. But think of it also as diabetes could even result in just a not suitable placenta. So it's just a bad placenta, which can result, the bad placenta could result in increased risk of, fetal defects, growth retardation, fetal demise. We have some management of this. We're doing a screening. The screening is done around 24 weeks to 28 weeks. Back in the day, this was a test where they had them eat pancakes and they evaluated how they kind of handle that on their body. But now it's a set 50 grams of glucagon. If that is still high, they're doing a 3-hour glucose tolerance test. And the goal is to have them euglycemic. They're having a tight control. Their natural insulin levels are just kicking in and just controlling that glucose level. Oral hypoglycemic agents do cross the placenta. and they're not previously used. We have some bloodborne diseases in pregnancy. We're doing treatment for the baby. So pretty much the first bath is immediately afterwards. We want to make sure all that maternal blood is on, that was presently on the baby, is now gone. And we're actually going to withhold the injections until after the bath. Likely these mothers could have a C-section. And we don't, when we're talking a bloodborne disease in the pregnancy, we're not doing any puncture of skin of the baby. So an example of that would be like an amniocentesis. Within the hepatitis B vaccine, this is a bloodborne disorder, almost 100% transmission at birth. Risk factors of this would be IV drug use, multiple partners, occasional occupational exposure. We do have a vaccine. It is hard to vaccinate high-risk patients prior to exposure. The standard of this is to test all women within the first and the third trimester of the hepatitis B surface antigen. And we're doing a vaccination of at-risk unvaccinated adults. We're going to prophylactically treat for the infants that are born to HBsAg positive moms. And then we just, of course, within standard cautions, we're going to try to do a routine infant vaccination once they're born. Group B, Streptococcus, GBS. A lot of times when you're hearing the prenatal chart of the mother, they're going to say, GBS positive or negative. So I would really encourage you to kind of be around that whenever they're talking about the moms that you're going to be around for clinical. There are risks with GBS if they're positive. That could be a stillbirth, neonatal death, or meningitis. And risk factors of this are going to be like prematurity, maternal fever, maybe their ruptured membranes is more than 18 hours. So pretty much GBS, I have it in red here. It lives in the vagina and rectum of about 20% of women, and it's no problem for the mom, but it is for the baby. It's actually very harmful, and it could even be very subtle signs and symptoms of this. So the longer that this rupture membranes is occurring does result in a higher risk of this. And we're doing that screening at 35 to 37 weeks. Within HIV and AIDS, we're make sure we're offering third and first trimester screenings, but we have to get consent for that. And sometimes they don't, sometimes they won't give consent for that. We want to make sure that we're monitoring infections, especially Candida albicans. Weekly non-stress tests beginning at 32 weeks to detect intrauterine growth restriction in the pregnant women with HIV. That would be the little purple here. That's the kind of kicker with this. And the med we're giving is retrovir orally. Can a HIV bomb breastfeed? The answer would be no. We don't want them breastfeeding, rather stated. We're going to avoid internal scalp electrodes. We're going to avoid vaginal exams after the ruptured membranes. We're going to avoid scalp sampling. And of course, we're going to avoid vacuum assisted deliveries. Usually it's a cesarean at 39 weeks. Okay, within cardiac, lung disease, and pregnancy, many types, there's many outcomes. Usually this is talking about congenital heart defects. Well, within really congenital heart defects, that doesn't really fall into this class. So we're just going to skip over talking about that. But with prenatal care, there are some testings that we can kind of do. Intrapartum, postpartum precautions. We're going to do a vaginal birth with the regional analgesic. 3 periods of increased risk would be 6 to 8 weeks, 28 weeks, and first 3 days postpartum. The problem prevention, how we're doing this is we're going to make sure that they're on a healthy diet, maintaining activity, and maintaining fluids. Within drug therapy for any of our cardiac problems that the mother could be experiencing, we are not giving them Lasix, and we are not wanting to give them Coumadin. They can be on heparin though. Heparin's okay. Hypertension does not get better with pregnancy. Oftentimes it could get worse. So we have to always be making sure that we're doing those prenatal checks of just evals and stuff like that. The effects of this can happen, any cardiac kind of issues. It's going to result in a decreased cardiac reserve, making it harder for the heart to kind of accommodate for the pregnancy because, you know, they have to naturally have an increased afterload to kind of help out with the baby. And the goal is to kind of prevent the worsening or just establish management of that. This next part here is talking about the differences between heparin and warfarin. But I would say focus on what we have in red here. Heparin is okay. Coumadin, warfarin is not, because that's going to cross the placenta. With hypertension in pregnancy, PAH, whenever you see that, it means pregnancy-induced hypertension. We're really thinking about the avoidance of preeclampsia, eclampsia. Chronic hypertension is when we have a blood pressure of 140 over 90 or higher before pregnancy or before the 20th week of gestation. Okay, within nursing care, nutrition, a sodium diet is usually limited. Restricted activity is to, these patients are on restricted activity, but not a complete bed rest. It's usually when we have preeclampsia that we're kind of doing that. With medications, unless the blood pressure is over 150, antihypertensive medications are not used during pregnancy. Preferred meds would be labetalol. ACE inhibitors are avoided. We would make sure that they're doing constant blood pressure monitoring and teaching them the effects that this could have on their placenta by having hypertension. All right, with preeclampsia, pregnancy-induced hypertension, we could have gestational hypertension, high blood pressure during pregnancy only. Preeclampsia is high blood pressure during pregnancy after 20 weeks with proteinuria and a previously normal blood pressure of women. Whenever you take the eclampsia on it, you're just adding seizures. But a rare complication of preeclampsia would be the HELP syndrome, hemolysis, elevated liver enzymes, and low platelets. And there's different levels of this. I wouldn't say you have to focus too much on that, but really understand. Well, you might have to focus. I mean, I would say you could always just glance at it, but I don't think that's going to be on it personally. With edema, this is no longer the criteria of preeclampsia, but it is common. We only have about 9 slides left, but I will post the recording. Okay. Okay. The goal of this is to stabilize blood pressure as long as possible. We do have a lot of nursing care here, but let's, of course, you can kind of read this, but let's talk about mag sulfate for a little bit. Whenever we're talking about mag sulfate, we have to understand that the antidote is calcium gluconate. Understand that this thing mag sulfate can be toxic. So we have to assess deep tendon reflexes. We have to assess ionos and their low leukostasis. We're never doing tongue blades anymore with patients at all. And we're needing to check their daily weight. You could look at the dosage here. It's a loading dose, then 2 grams per hour. 5 to 8 is therapeutic, not the normal. Of actual magnesium itself. So pretty much we're giving this med, we expect it to be a certain level, but we don't want to be toxic. Okay. All right, mag sulfate is the med to prevent seizures. It's a vasodilator. It's given IV. We have to make sure we're assessing respiratory distress. Early signs of toxicity would be decreased deep tendon reflexes and a decreased level of consciousness. And then, of course, calcium gluconate. Whenever we're talking about the classifications of a miscarriage, I would say go back and look at what we talked about in the SI session. I believe it was either 2 or 3. But we went ahead and we did a practice question over this. So, I mean, not knowing if it's even going to be on the exam, because it is a little tricky, but once you do that first practice question, it'll already help you with this content. Whenever we're talking about nursing care of this, though, everything has to come out, because if it doesn't come out, it's going to cause more bleeding. Rogam is going to be given if Rh negative. Of course, think about it. Antibodies are going to be made. If not, the first trimester, there we have a dilation in curettage procedure. It's very invasive. Think about it as a scrapage of ensuring all the products of conception are out, monitoring for infection, and really excess bleeding as well. And if it's a spontaneous abortion miscarriage and it is beyond 12 weeks, a lot of times they'll actually just induce the labor. It's safer, and I would imagine it'd be very painful, but it's just safer to kind of induce that baby. I remember learning some teaching as well that sometimes it helps them kind of process the actual loss if they do actually induce and deliver that their fetus as well, versus just waking up and them having a scar, and it's just mourning the process as well. Sometimes we have an ectopic pregnancy. That's when it didn't implant right, and it's usually in the fallopian tube. These mothers right here will have a delayed loss of menstrual period and signs of pregnancy. So they will have the very high HCG hormone, but they will also have unilateral lower abdominal pain, and this can actually be also referred to the shoulder. This, like a referred pain, from first semester. This is not a viable pregnancy, though. This is whenever it's a pregnancy that's going to be in the fallopian tube. If allowed, it definitely would burst. Rupture could really lead to hypovolemic shock or even death. And it's usually confirmed by the ultrasound. They're going to assess where actually everything is. So pretty much that's what it is. If caught early, they can actually give methotrexate, and the HCG levels should diminish. Okay. Molar pregnancy, gestational trophoblastic, this really big word here. This is whenever it is also not a pregnancy, and they will have hyperemesis. They're going to have very high HCG levels. This is the one that on the X-ray, it looks like a big snowball. This is, they're probably going to have very high blood pressures with this, and upon assessment, there's actually going to be no fetal heart tones, low levels of maternal serum alpha fetal protein, and this is diagnosed by a transvaginal ultrasound. We have to make sure teaching these mothers to avoid pregnancy for a year. This could be a cancerous precursor. And it's a safety thing. A collection of rapidly producing precancerous cells are what makes this up. It increases the HCG levels until the baby's terminated. The baby will die, but this is what it does. They're going to have a positive pregnancy test because that HCG levels are just through the roof. But then again, no fetal heart tones. It's not an actual baby. Heart tones with the Doppler will be present well, should be around 8 to 10 weeks. That's kind of when they find out that this is not there. But yeah, this is usually also associated. I like to think about this associated with our next slide here, hyperemesis gravidarum. This is when we have a very high level of nausea vomiting. It's an extreme nausea vomiting without an onset of pregnancy. The placenta isn't made, and the levels of HCG are just through the roof. We could definitely have complications of dehydration, even weight loss, up to 5% of the pre-pregnant weight. We're looking for, of course, like all vomiting patients, we're afraid to have hypokalemia. And even with this lack of, the risk for fetus could be lack of fetal growth. With the nursing care, we have it all written here, but really we want to establish IV access to kind of get some fluid administration going. We're going to give them antiemetics. And we're doing small, frequent meals, small ones, okay? Okay. Okay, with urinary, I'm sorry, I read that wrong. With RH sensitization, we've already kind of talked about this, but we'll just read what we've highlighted here for the little summarize. Unsensitized patients are going to receive RhoGAM at 28 and then 72 hours afterwards, of course. The RhoGAM tricks the mom's body into thinking that she's already made antibodies. Anything that can cause a mixing of the blood, we're going to give RhoGAM likely. Sensitized clients do not receive that. Please write that down 3 times. Sensitized clients do not receive RhoGAM. Sensitized moms have already made the antibodies. And usually the first pregnancy is fine because it is not the affected pregnancy. Okay, with UTIs, signs and symptoms would be back pain, painful urination, lots of urinating, polyuria, cloudy urine, and then odorous urine as well. Preterm labor could be associated with this because UTIs are a risk. It can feel like normal back pain. It's often not caught. Complications of UTIs could be sepsis, could be also pyelonephritis. Prevention of this, they're going to do a test dipstick at every prenatal visit. It's always better to have the mom come in and test it than to be safe, than regret it later. Okay, this is our last slide here, but vaginal infections, signs and symptoms would be a thick white discharge, a yeast infection, babies at risk, breastfeeding problems, BV, bacterial vaginosis. We need to treat both partners. That would be the main takeaway with this. Bacterial vaginosis, treat both partners, both mom and baby for yeast infections as well. STIs, risk factors, young maternal age, maybe multiple partners as well. HPV, warts or genital warts. We have easy transmission, and they have to become immune before exposed. They can cause growths, and you don't usually need a C-section unless the growth blocks the birth canal. But if you're really, really worried about this slide, I would say just skim over it. If you are curious about other stuff on this PowerPoint, then focus on that more, okay? This is not a priority here, and I promise you this stuff is later exams, okay? And then good luck on your exams. Have a positive mind, have positive vibes, and have a positive life for these next couple days. Just study as much as you can. Of course, there's a Super Bowl, but try to just get your stuff together, and I promise it will turn out okay for this first exam. Thank you.